In 2022, 941,652 Americans died from cardiovascular disease, one death every 34 seconds. As we've learned on this show and through the efforts of all the great plant-based doctors and the folks here at PPMNY, so much of cardiovascular disease is preventable and even, dare I say, reversible through a plant-based diet and other healthy lifestyles. But then some people learn they have elevated lipoprotein A, typically referred to as LP little a, and that it heightens their risk factor for cardiovascular disease. So, what is that? Is it the same as LDL? What can they do to prevent the onset of disease? Tonight, we're honored to welcome back cardiologist Robert Ostfeld, who will help us understand more about this risk factor and what we can and can't do. And what we want to do right now is welcome my co-hosts. I'm Jim Spellos from Plant Powered Metro New York. And along with Judith Zerden and Ben Martins, we welcome you to another episode of Heart to Healthy Heart, plant-based conversations that can save your life. As always, we encourage you to use the chat box to tell us where you're viewing from, as well as to ask any questions of our special guest. And we'll try to get to as many of your questions as our 30-minute time slot can accommodate. And so now let me introduce our guest for the evening, Dr. Robert Ostfeld. Dr. Ostfeld is Director of Preventive Cardiology at Montefiore Health System and a professor of medicine at the Albert Einstein College of Medicine. He treats patients with adult cardiovascular disease, including coronary artery disease, hypertension, hyperlipidemia, and erectile dysfunction, with a focus on prevention and treatment through lifestyle change. He works closely with his patients to help them adopt a low-fat, plant-based diet. Dr. Ostfeld, once again, as always, it is an honor to have you on the show. Thank you so much for your time tonight.
Well, thank you so much for having me. It's terrific to be here with you all, and I love the work that your organization does. It's just absolutely phenomenal. So thank you for having me, and thank you for the very generous introduction.
Well, I understand you have a short little presentation, then we'll have questions from us and questions from the audience, so take it away.
Well, thank you so much. I was asked to keep my presentation pretty short because I was advised there were a bunch of questions, which is terrific. And so I'll give a very brief talk about lipoprotein little a. I guess hopefully I have the correct one in here. The correct version of the talk in here. I think so. Anyway, so first I thought I'd start, just a little bit of background. I've been a cardiologist now for a little over 20 years. And when I first started working here at Montefiore, I did all the things that I was trained to do: lifestyle change, medications, maybe a Mediterranean style diet. And people got a little bit better, but they didn't get tremendously better. And I was kind of getting a little disillusioned. And one thing led to another, and learned about the impact of a plant-based diet and started a cardiac wellness program here at Montefiore with the goal of preventing disease with a plant-based diet. And I say disease, not just heart disease, because, sure, eating a plant-based diet is good for your heart, but it's good for you for dozens and dozens of other reasons. And we've had the honor to take care of now thousands of patients over the years on an inpatient and outpatient setting, and just never seen the breadth and depth of benefits that a plant-based diet provides. So it's really rejuvenated me as a doc, and it's a wonderful thing that we're able to use, and it's terrific that this organization helps move it forward in such a practical, rubber meets the road kind of way. And so today we'll talk a little bit about lipoprotein little a. So lipoprotein little a was first discovered in the early 1960s, I think 1963, and an investigator was actually looking for a new kind of blood type, like we're type A, type B. He's looking for a new type of blood type, but kind of just by happenstance stumbled across lipoprotein little a. And it was some years later that its true pathogenicity was identified. And lipoprotein little a is very similar to LDL cholesterol, but the big difference is that it has a compound attached to the LDL particle called apoprotein A. It's a protein that just sits on the top and is bound to the LDL particle. So why does that even matter? So lipoprotein little a which is really the LDL particle with the apolipoprotein covalently bound to the LDL particle, is unfortunately particularly atherogenic. About 90% of its level is determined by our genes, maybe 10% or so by lifestyle. And lipoprotein little a is about 6 times more atherogenic than the typical LDL particle. The good news is typically we have far, far fewer lipoprotein little a particles than LDL particles. Now, why might lipoprotein little a be more atherogenic, meaning causing more atherosclerosis than an LDL particle? Now, they both cause atherosclerosis, and the lipoprotein little a does have an LDL particle as part of it, but the apolipoprotein A portion that's attached to the LDL particle does some other things that are important. One of them is that they have a lot of oxidative phospholipids on them, and that can promote inflammation in the vessel wall. So we know that the LDL particle, same thing for the lipoprotein little a, can burrow across the endothelial cell into the wall of the artery, where they can create inflammation and promote atherosclerosis, while the lipoprotein little a is supercharged in that regard. And also on this apolipoprotein A particle that's attached to the LDL, it also may reduce the ability or make it harder for us to break up blood clots, or make it easier for our blood to clot in our arteries. And as you know, when there's a heart attack, blood clots can happen within the blood vessel where you don't want it to happen. And this LDL lipoprotein little a particle makes it easier for those blood clots to grow. So that's not your friend as well. And so it's particularly pro-atherogenic because of the oxidative phospholipids creating inflammation, oxidative stress. Also, it can make your blood more likely to clot. Another element of lipoprotein little a, which adds to its kind of portfolio of bad actorness, is that it makes us more likely to develop a heart valve lesion called aortic stenosis. And the aortic valve is in between the left ventricle of the heart and the aorta, which is the pathway to blood flowing to the body. So when the left ventricle squeezes, blood goes across the aortic valve into the aorta, into your brain, your kidneys, your feet, all over. But if the aortic valve doesn't open normally, it's very tight, like there's a traffic jam, then it's much, much harder for the left ventricle to squeeze blood to the body. And over time, that can cause all kinds of problems. It's not an uncommon heart valve lesion, but when you have lipoprotein little a, some of those particles can get into the wall of the valve and create inflammation there. And over time, slowly but surely, make the valve tighter and tighter till it could become very tight, requiring some kind of procedure to open it up. So why in the world would we even have lipoprotein little a? And it seems like forever ago, having it when we were young may have had a survival advantage. If it makes blood more likely to clot, perhaps during childbirth, it protected people from bleeding to death. So it would have a survival advantage. But that survival advantage is when we're younger. It's not really a survival advantage when we're, 70 or 80 years old. So things that may be helpful when we're younger are not as helpful when we're older. So that's a hypothesized reason as to why we have it. Now, and higher levels do promote atherosclerosis, heart attack, aortic stenosis, blood clots in the arteries, like we mentioned. And unfortunately, there's really not a lot that we can do about lipoprotein little a right now. Its level, as noted, is largely genetically determined. And we don't honestly even know if lowering lipoprotein little a is helpful. We hypothesize that it is, but we don't know that. And there are studies ongoing right now looking at medications that can quite effectively and specifically lower lipoprotein little a. And the first one of those should report out hopefully later this year and give us a much better sense about first the causality of lipoprotein little a, which we think it's causal for these issues that we discussed, and to kind of, tie that into a bow one way or the other. And also we will learn whether specifically lowering it is helpful. So there's much left to learn, but this is, elevated lipoprotein levels may account for, some cardiovascular risk that we're not currently able to address. What was the other point I wanted to make? I'm just blanking on it right now. The current recommendation is that perhaps lipoprotein little a could be checked once in a lifetime. And we currently use it as a way to help us modify other risk factors. For example, if we're on the fence about whether someone may need a statin for their LDL particle, if their lipoprotein little a is also high, that would tip us over to starting the statin, because we would know that they're facing another risk factor that we don't currently have any therapy for, and we want to optimize all other risk factors. And so we will use it as an opportunity to triple down on lifestyle and possibly adjust medications so that we can optimize every other risk factor. And of course, use it to help people adopt a healthier lifestyle, knowing that there is a risk factor that we are not able currently to address. So in summary, lipoprotein little a can promote atherosclerosis and aortic stenosis and possibly make blood clot. It's largely genetically determined. Its level is largely genetically determined. We use it clinically currently to help us think about optimizing all other risk factors, including lifestyle. And we'll soon know a lot more about whether lowering lipoprotein little a is helpful, and whether using certain medications to specifically do that can prevent or can reduce cardiovascular risk. So here's my second slide. Just tangentially, we created a cardio nutrition podcast with the American College of Cardiology some years ago. And if anyone's interested in listening to that, we have about 20 bite-sized interviews. You can pull that up here. And this is our clinic in Manhattan. Montefiore opened up a really lovely outpatient clinic in Manhattan West, right next to Moynihan Station. And we're seeing preventive cardiology patients there as well. So thank you. It's a real honor to be with you all here. And I look forward to taking some questions.
Fantastic. Thanks. We have a bunch of questions already coming in from the audience, but the team here has a few. And I'll just lead it off, Doc, by just asking is what's a normal number? And is there a normal number for LP little a?
So there are ranges, and there are two different units that are used to measure it. There's milligrams per deciliter and nanomoles per liter. It's felt that nanomoles per liter is more optimal, because the mass of the lipoprotein little a particle can vary from person to person, and so but they're pretty similar. If you're using milligrams per deciliter, over 50 really is considered high, and for nanomoles per liter, more than 125 is considered high. But there's nothing magical about 124 or 125 and 49 and 50. It does seem when levels are a good bit lower, the risk is kind of flat. But once you're hitting, say, 30 for milligrams per deciliter, maybe 50 or so for nanomoles per liter, the risk really does start to climb. So it seems to be that might be the optimal range, but technically high is more than 50 milligrams per deciliter, 125 nanomoles per liter. And oddly and interestingly, it's been noticed when people have quite low lipoprotein little a levels that there's actually an uptick in diabetes incidence. Now, we don't know if that's causal. We'll certainly know more about that with these medication trials, because they lower lipoprotein little a lot. And some studies suggest that that's just a relationship that's not really real, just as kind of by chance. So that's the optimal range is probably, I don't know, somewhere 10 or 12 if you're thinking about the diabetes risk on one end, and maybe less than 30 or 50, depending on the units we talked about, on the other end. And it's kind of a curve like that.
Judy?
Hi, Dr. Ostfeld. I know you covered most of this in your talk presentation, but could you just walk us through, if somebody has an elevated level of LPA, what steps would you typically recommend for them?
Yeah, so that's a great question. It's really important. So I guess a number of things. Obviously, you have to think about in the context of the person and what's going on with them clinically. So first off, we're going to want people to live as healthful a lifestyle as possible. From my perspective, I'm going to want them to have as close to a whole food plant-based diet as possible. But nevertheless, in the face of a high lipoprotein little a, we certainly use that as a means to double down on lifestyle. Maybe some people aren't as interested, or maybe they're having trouble finding time to exercise. So we'll use it to be like, look, we're facing this risk factor that does increase your risk of heart attack and maybe aortic stenosis. And having as healthful a lifestyle as possible is critically important to protect you in general. Now, we don't know if that's going to protect you specifically from lipoprotein little a, but we know it protects you in general. So that's one. So lifestyle would be number one. Number two is, we can use it if we're on the fence about a statin. It's actually the guidelines, American College of Cardiology, American Heart Association guidelines call it a risk modifier. When it's high enough, I believe the cutoff is, I think they're 75 milligrams per deciliter, I think, per milligram, in that a little bit older guideline now. That would be a risk modifier and be one of the ways that would tip us to use a statin. Interestingly, the injectable cholesterol-lowering medications, the PCSK9 inhibitors that are exquisitely effective at lowering LDL cholesterol, also lower lipoprotein little a by about 25%. So sometimes, we'll consider using that, with the hypothesis being that could, maybe if we lower lipoprotein little a, that'll be helpful. But we don't honestly know that for sure, so we're sort of hoping. But that's another situation in which an elevated lipoprotein little a would help us adjust therapy. And if it's quite high, we would recommend that person ask their first-degree relatives to have their levels checked, because there is, of course, a genetic component, and then they may be able to rethink about how they're optimizing their other risk factors.
Hello, Dr. Ostfeld.
Ben?
Can a whole foods plant-based diet lower LP little a?
So we don't unequivocally know that. I should start with, because that question is fed with a lot of optimism, and it might be right, but we don't know. We do not know if lowering lipoprotein little a is or is not helpful, period. We hypothesize and think that it is, and we'll know a heck of a lot more when a number of studies report. But I don't want to give false hope about anything. There was one small case series done by the late Dr. Baxter Montgomery and Dr. Najjar, their team. It was a small case series where a plant-based diet was able to lower lipoprotein little a by about 16%. Whether that is or is not helpful specifically for lipoprotein little a is not known. But that did lower it a little bit. Dr. Kevin Hall at the NIH some years ago did a randomized controlled metabolic ward study, and they found that actually an animal-based keto diet lowered lipoprotein little a, raised other things. But so that's so we don't really have a lot of great guidance in terms of what lifestyle can do, specifically in regard to lipoprotein little a. But that's okay, because a whole food plant-based diet is good for us for so many other reasons that we don't need to be discouraged right now that it doesn't seem to, profoundly impact lipoprotein little a, whether that even matters.
Okay, now waiting for the studies for sure. If the answer is no, that it doesn't bring down the LP little a, would then the other bringing down, would it be more important in this case to bring down the other bad cholesterol numbers?
Well, you're absolutely right that currently we want to be sure, it depends on someone's level of baseline risk. If they have very bad heart disease or if they're otherwise perfectly healthy, we want to be sure that their cholesterol, particularly LDL or ApoB containing particles, are quite low, as appropriate and guideline driven. We would certainly want to do that with a combination of lifestyle change and medications when needed. Being sure that blood pressure is at goal. We're addressing any potential diabetes, obesity, sleep, exercise, psychosocial support, all of the aspects of lifestyle medicine. They're all important, of course, whether lipoprotein(a) is high or low. But when it's high, that's extra reason for us to want to make sure that we've got everything else optimized.
There's a question that came in from the audience that I want to share, and it is, does Lp(a) count as part of LDL? Does it increase that number inherently?
Yeah, some of the assays for LDL, it does count it as an LDL particle. So it does. Some of them don't distinguish the two. Usually there's way fewer lipoprotein(a) particles. So it's kind of doesn't really impact it a ton, but yes, they are lumped into the same category. They both have an ApoB containing particle, and there really is an LDL particle attached to the apolipoprotein A in lipoprotein A. And so the LDL aspect of lipoprotein(a) is indeed atherogenic as well.
Judy?
Yeah. Should everybody get an LPA test? It's not part of the normal lipid panel yet.
There's a little bit of controversy about that, but guidelines and societies are beginning to align, are aligning that lipoprotein(a) should be checked once in a lifetime, and perhaps again post-menopause in women, because it does seem to go up 15-17% after menopause. So that's, I don't know how early in life they're recommending it, as I'm an adult cardiologist, and it does seem though that lipoprotein(a) levels kind of reach their lifetime baseline after 2-3 years of age. After 2 or 3 years of age, but it is currently recommended, largely alignment that it being checked once in a lifetime for now. And, if it turns out that these medications work, well, then that's obviously going to change a lot, but that's where things stand right now.
So if somebody tests positive for elevated LPA, should their immediate family members also get tested because of the genetic component?
Yeah, that's a good piece of advice and a good rule of thumb to have. Yes.
How prevalent is high LPA?
So it's about 20%, 1 in 5 people have elevated lipoprotein(a) levels. It's a little bit arbitrary because that's sort of how they define it, but about 20% of the population. It does vary by ethnicity, where East Asian seems to have the lowest, South Asian middle, African American highest.
Okay. So Lawrence, I'm sorry, I didn't see that you asked the identical question that I was about to ask one of our audience members. Anyway, you had mentioned the drugs in development in the clinical trials, and could you tell us more about that? I think that's really a very exciting thing that's going on right now with Lp(a).
Yeah, well, thank you. The one that's closest on the horizon is actually called Horizon. And that one's technically supposed to report this year. I guess at least the top line results. I don't know exactly when. It's sort of been, people have been hoping for the last couple of years. But anyway, so it's supposed to report this year. And they take people with heart disease, pretty high risk group, which is common with newer medications. You typically start with a higher risk population. So if there's going to be a difference, you'll see it. It's harder to see a difference in perfectly healthy people. And so with high lipoprotein(a) levels, at least 70 milligrams per deciliter, and they're given a medication that actually can interact with the mRNA in our cells and profoundly lower lipoprotein(a) levels. I think about 80% or so, and some of them even more than 90% of the medications in studies. So quite a lot, and quite specifically lower lipoprotein(a), not other things to confound the picture. And so they've been following, it's going to be something around 8,300 people. And they're looking at, major adverse cardiovascular events as the primary outcome. It's versus placebo. So we'll see. It's supposed to report this year. There are a couple of other studies that have either, I think both of them have launched. One is Ocean, which launched in 2022, another somewhat similar medication that affects mRNA and also profoundly lowers lipoprotein(a). And then there's Acclaim that I think just started, a similar kind of theme. They're studying somewhat healthier groups than the Horizon study is, but the Ocean study I think is supposed to be done in around 2026, and the Acclaim one in around 2029. So it's going to be an exciting time. And there's other molecules that are being looked at in this space as well. But, the horizon is hopefully close for Horizon. I think it's going to be this year.
Yeah, doctor, semaglutide drugs, do they affect LDL cholesterol levels, LP(a)?
I don't think so. Maybe there's some, when people lose some weight, there may be impact, but I'm not 100% sure. I don't think they meaningfully impact LDL cholesterol or meaningfully impact lipoprotein(a). I know I looked it up before. I cannot remember 100% off the top of my head.
We're about out of time. There's one more question that actually is more of a statement, but we'll phrase it. Why don't doctors tell us about it? Is it because they don't know much about it, or why isn't that part of the constant conversation that you have with your GP or your cardiologist?
Well, I think part of it is because there's nothing that we can really do about it now, specifically. So I think that impacts the discussion. And there's so many things that we can do things about that, and there's limited time, and you want to be sure blood pressure is good, and the diabetes medications are good, and the various screenings are done, and you've got their LDL cholesterol good, and lifestyle. There's so many things that we can do that takes up a lot of time. And the lipoprotein(a) really is going to impact things, on the margins in terms of at least adjusting medications now. Now, of course, it is recommended to be checked once in a lifetime. We should be talking about it. You're 100% right. And, maybe that'll particularly motivate someone and help us learn more about their family. So I agree. We should be talking about it. It's only somewhat more recently that it's gotten attention. So for those, gray beards like me who went through med school forever ago, we certainly weren't talking about it in med school. So there's a learning curve aspect. There's a, what are we going to do exactly with it differently aspect? There's so many other things. But yes, ideally, it would be checked and would be addressed.
And with that, I hate to say that we are out of time. The half hour flew by, but on behalf of all of us, Dr. Ostfeld, we are so appreciative of your time and your expertise tonight. So thank you for joining us this evening.
Well, thank you very much. It's a great honor to be here with you all.
And let's just wrap it up with a few announcements here. Upcoming on Heart to Healthy Heart is a 3-part series on SOS, salt, oil, and sugar, and their impact on cardiovascular health. Up first on Thursday, the 24th of July, is Shaking the Salt Habit, How Cutting Sodium Supports a Healthy Heart. We will have Dr. Kim Scheuer, a board-certified family medicine and lifestyle medicine physician from Love Life Telehealth, with us that day to have that conversation, one that I know a lot of people are interested in. As always, if you want to watch any of our episodes again, they're all on the Plant-Powered Metro New York YouTube channel. On behalf of Judy and Ben, I'm Jim Spellos, wishing you as always optimal health, and we look forward to seeing you again next time on Heart to Healthy Heart.